When placing a dental implant, relying purely on the surgeon's tactile feel or baseline insertion torque to decide when it is ready for a crown is an inherent gamble. The standardized healing timelines assume every patient's biology responds uniformly. To remove this guesswork, clinicians use resonance frequency analysis or RFA. This diagnostic tool objectively measures the microscopic stiffness of the interface between the implant and the surrounding bone. The system translates this stiffness into a quantifiable digital readout called implant stability quotient or ISQ, scoring it from 1 to 100. During a reading, the device emits an energetic shock wave that ripples down the titanium screw, traveling deeply into the dense porous bone matrix. The return frequency reveals exactly how tight the biological grip really is. Transitioning from the surgical intuition to standardized biophysical data prevents the primary cause of early biomechanical failure, loading an implant before it is completely secure. The traffic light system breaks the 1 to 100 ISQ scale into three risk stratified bands. The green zone 70 or higher indicates excellent mechanical stability. The yellow zone 60 to 69 is a transitional buffer. The red zone below 60 indicates dangerously low stability. Taking this initial reading at the exact moment of surgery provides a baseline score. That specific number immediately indicates the safest restorative plan for the patient by locking in the mechanical stability on the day one. The surgeon explicitly defines the initial risk profile, avoiding the catastrophic error of applying immediate bite pressure to an unsupported fixture. If an implant scores securely in the green zone, the protocol is straightforward. The surgeon is cleared to proceed with immediate or early functional loading. There is a notable exception for full arch rehabilitations like an all on four because a rigid splinted framework distributes bite forces evenly across the multiple sites. A high global stability score can permit the safe loading of single marginally stable implant. Implant scoring in yellow zone requires patience. The standard protocol dictates a conservative transitional healing period of 3 to 6 weeks before any load is applied. Falling into red zone triggers a strict fallback plan. These cases require a rigid two-stage submerged healing protocol, keeping the implant completely isolated from the oral environment. Alternatively, if an extreme red zone score registers on the operating table, the surgeon might intervene immediately by replacing the fixture with a wider or longer implant to force better primary stability. While these static protocols manage the initial post-operative risk, they only represent a snapshot in time. They cannot account for complex biological changes that will occur over the following weeks. The reality of osseointegration is highly dynamic. Once the surgical site is closed, primary mechanical stability naturally degrades as the body begins the process of bone remodeling. This graph maps the exact temporal dynamic. It plots healing time in weeks on the x-axis against the ISQ value on the y-axis, layered over our red, yellow, and green zones. The first curve represents primary stability. It starts high on x-axis on the day 1 but slopes deeply downwards over time. This downward trajectory illustrates the mechanical grip physically loosening due to natural osteoclastic activity, clearing away traumatized bone. Simultaneously, a second line representing secondary stability begins at zero and gradually slopes upwards, eventually crossing the first curve. This rising trajectory is the biological cascade of osseointegration actively taking hold. When we sum these two curves, we get a solid line representing total stability. It starts high, dips notably in the middle, and then rises again. That vulnerable valley is the transitional dip. It is the exact window where the total stability threatens to drop down into a lower color zone. The clinical power of the ISQ system is its ability to map this invisible biological handoff, isolating the precise moment of bone begins supporting the structural load. Under ideal healing conditions, longitudinal tracking reveals a positive trajectory. An implant that starts deep in the red or yellow zone will steadily climb upwards over several weeks. The clinical protocol for this scenario dictates withholding any functional load until RFA data proves the implant has crossed into the green zone. However, look at this total stability curve. It starts securely in the green or yellow zone but then sharply drops downwards crossing back into red zone. This negative trajectory signals a biological emergency. It points directly to crystal bone loss or an unfavorable reaction if early loading was attempted. A downward drop immediately triggers clinical intervention. The practitioner must step in to unload the prosthesis, adjust the occlusion, or extend the submerged healing period. By continuously tracking these trajectories, a clinician can diagnose and reverse an impending failure long before the patient ever experiences symptomatic mobility or pain. Longitudinal tracking becomes mandatory when treating complex surgical cases where the standard cascade of osseointegration is compromised. Specific patient profiles present distinct biological hurdles. Individuals managing diabetes, severe bruxism, or those receiving implants directly into sinus lifts and grafted bone. On this graph, empirical timelines fail. The standard curve climbs into green, but the high risk curve stalls in yellow. Standard calendars are discarded for hard data. Procedures remain suspended until tracking yields a definitive green light, a score of 70 or higher. The traffic light system protects high risk patients by forcing the treatment plan to adapt to biophysical evidence rather than relying on optimistic clinical assumptions. The ISQ traffic light system serves dual purpose. It provides a vital day one baseline metric and acts as a dynamic longitudinal map of osseointegration. Applying this framework removes the subjectivity from the implant dentistry. It replaces tactile intuition with an objective standard for risk stratification. When properly managed, the result is perfectly integrated titanium fixture, tightly surrounded by dense bone, easily resisting heavy downward compression without shifting. By strictly adhering to these standard stability zones, the clinician can navigate the vulnerable healing dip, actively prevent biomechanical failure, and ensure a safely loaded restoration for long term clinical function.